I'm Dr. Anthony Cave, a Stanford and Harvard trained anesthesiologist and integrative medicine specialist. And I recently had a patient that not only woke up in the middle of their surgery, but made this flexural response, nearly grabbed me from one side of the drape and grabbed the surgeon from the other side of the drape. And thank goodness there was no knife in the surgeon's hand, but they could have seriously hurt themselves and hurt me and hurt the surgeon all at the same time. There was nothing going on during this point in the surgery. It was what I believe to be the nightmare that the patient told me about after they woke up and we talk about the whole situation. So, what was the traumatic experience that this patient had? How did it come out under anesthesia? The patient couldn't be fully asleep. They had to be semi awake for the success of the surgery. And even on the brink of consciousness, that PTSD came out in a way that nearly jeopardized the whole surgery and their own health. So, what is PTSD is what we're going to talk about, and specifically medical PTSD, how it can complicate surgery and anesthesia. What are powerful tricks to overcome PTSD, specifically before surgery? What is the depersonalization or the dissociative state that some patients go into before surgery from PTSD? How does it help? How does it hurt? What are some of the most powerful trauma-based psychotherapy methods out there? How can they help you? How can blunting the sympathetic nervous system during exposure therapies be so instrumental before surgery? And maybe most importantly, how can you talk to your doctors before you have a medical procedure so that you are heard by them and they can maximally help you have your PTSD in a safe place before your surgery, before any medical procedure? Because doctors don't like talking about PTSD unless you're a psychiatrist because we cannot directly measure it. But when PTSD rears its head in the operating room or in recovery, yeah, then you can see what happened then, but it's too late. So, how can we be ahead? How can we be preventive for PTSD causing serious complications in such a vulnerable time for patients? It depends on how we talk to our doctors to help prepare them for it, to help prepare them for it as much as we prepare ourselves. So, I'm so happy that Chris is on here, Bree Bratt, Jody, Mary, Jay. Thank you all for coming on, and Chris for suggesting this important topic because so many of my viewers and patients struggle with this before surgery. So, first, what is PTSD? Simply put, dysregulated memory consolidation. When we have a traumatic experience, we have them all the time, they don't always go on to an acute stress response and PTSD. Most stressful experiences get consolidated in our brain. They go to a place where they can be accessed again in the future, but accessed in a way that provides information doesn't necessarily provide the same vivid smells, visualizations, what we heard. It doesn't simulate our heart rate to go up, our palms to get sweaty, our blood pressure to go up, our heart rate variability to go down, our pupils to dilate. These are all physical manifestations of an acute stress response. I see it in the operating room all the time, sometimes just from them seeing the oxygen mask that I'm holding here as an example. So first of all, it's incredible that a external stimulus can cause our body to go into this fight or flight response. But specifically, the problem is that that initial traumatic memory didn't get consolidated. So consolidated in a way, I should say, that allows for it to be recalled without this sympathetic drive. So when some vets come back from war, they'll acknowledge the horrible things that they saw, but they'll say that, oh, maybe it was part of a greater cause. They bonded with so many other fellow brothers, accomplished a common goal. Versus those that look back at a traumatic experience during that same combat and will remember exactly what happened when the shrapnel hit their comrade's face, exactly what they heard, exactly what they felt, the time of day, what was on their skin, how much they were sweating. These are two different types of recalling a memory. One of them can lead, or one of them is a hallmark of PTSD. Now, medical PTSD is different because when you're in a hospital setting, we are giving you sedatives. We're giving you maybe anesthesia if you're having surgery. You're having your circadian sleep cycle completely disrupted in a hospital. Have you ever tried sleeping in a hospital? You're taking your blood in the middle of the night, taking your vitals. it's not like normal sleep. Well, if you're not sleeping normally, if you're being given pain medications, if you're being given sedatives, these are all messing with your memory. So that we might not remember particular traumatic situations or experiences that weeks or months later might be giving us PTSD symptoms. Now, the most extreme case will be if there's anesthesia awareness, like you're in surgery, supposed to be asleep under anesthesia, maybe with the breathing tube like this past your vocal cords, but your memories are so scrambled from the anesthesia that if you had a little bit of awareness, like maybe you felt something on your body, or maybe you heard a conversation, if your eyes weren't taped closed, maybe you saw something. Maybe it wasn't pain, but whatever it was is not able to be processed by your brain as a memory. So you might have the symptoms of PTSD, but not be able to remember what was that traumatic episode or experience that's causing these feelings in me now. Now, this can lead to that dissociative state we were talking about, which is another hallmark of PTSD. Before surgery, in particular, some patients will be disassociated from their body, literally separating themselves from their body as a type of coping mechanism so that they can separate themselves from that danger. Because one way of looking at this, I'm trying to put words to something that inherently can't have words put to it. So it's kind of a metaphor here, but if we're not in our bodies, this perceived threat can't hurt us. We're looking at it from somewhere else. That threat isn't real if we're not in our body for it to affect us, right? It's difficult to explain this dissociative state for someone who has not experienced it. But over time, this can be a deleterious, absolutely harmful way of trying to cope with that trauma. And before surgery can lead to complications, not just the experience that I shared, that story, which was really something else. That's quite rare, but can lead to things like increased risk of postoperative depression, anxiety, or panic attacks before surgery or after surgery, worse pain after surgery, you name it. This is why so many of the trauma-focused psychotherapy methods that have a lot of evidence behind them focus on exposure therapy. How can we expose ourselves to the inciting trauma so that when we do have that perceived threat again, we have toned down our body's response to it, one, but two, we've also helped put that memory back with other normal memories, not with traumatic memories that will cause that same vivid recall, that blood pressure changes, heart rate changes, pupil dilation, etc. So the goal of the exposure therapy is to help this become like another traumatic memory. We're not saying it didn't happen, but doesn't need to be as vividly relived every time it's triggered. So maybe you've heard of things like written exposure therapy, narrative exposure therapy, EMDR. There's a handful of them, and there's good evidence for them. What I like to do specifically, because I'm an anesthesiologist, I have other tools that I use, not only in my psychedelic clinic, but also outside of there, we give beta blockers during those exposure therapy sessions to help mitigate and to help minimize or attenuate the sympathetic nervous system response when these traumatic experiences are being relived again through an exposure. The idea being that if we can lower the sympathetic drive when that exposure is happening, we can help this memory be consolidated normally. Now, this is why we give lipophilic beta blockers like propranolol that can infiltrate fatty tissue because, hey, the brain's fat, right? So you got to be able to get into those tissues. You have to cross the blood-brain barrier so that exposure, whether it's written, narrative, EMDR, prolonged exposure, etc., we can not be as so physiologically deranged, and I don't mean deranged in a bad way, but have it be so spiked up so that we can actually focus on consolidating the memory safely. Now, that being said, there's so many people in here that I need to say hi to. Sarah, good to see you. We already said hi to Jody. Mary, all right. Laura Amos, hello back to you. And Sarah Matthew, our study tips. We can talk about my study tips in a different video. We will talk about that soon, though, I promise. Savannah, good to see you. You're jumping into the next topic. Savannah says, I've tried to tell my doctors before surgery about my medical PTSD from the poor treatment from years as a patient with chronic health um, conditions, and I'm ignored. Okay, so how do we talk to our surgeon, our anesthesiologist? First and foremost, one of the most powerful ways of being able to address medical PTSD before surgery is exposure therapy, specifically with your anesthesiologist bringing you into the operating room, bringing you through the recovery area into the post-operative area. That exposure with a trusted individual, a guide, is one of the most powerful ways that we can overcome PTSD before surgery. Because we know PTSD has risks around the surgery period. There is an urgency to get it under control so that we can not only live our lives, but also have fewer surgical risks, anesthetic risks, etc. When we go through the operating room, being with a trusted individual is paramount because having the traumatic experience is not sufficient for developing PTSD after. You have to have the traumatic experience and have inadequate coping mechanisms, such as in the form of not adequate social support. So if my patient, for example, is having surgery, they're a little bit awake and they don't know who their anesthesiologist is, who their surgeon is, the nurses, or anyone else, they're not going to feel the maximal amount of trust in the care team that they could otherwise. So you have a traumatic experience going on, like maybe you feel something or your body is feeling something, even if you don't remember it. By the way, that patient I told you about at the beginning didn't remember any of what happened because our memories are scrambled. Anesthesia recall is a very tricky thing. Anesthesia awareness is not straightforward, and this is why the PTSD can be so challenging. And by the way, Hannah's talking about delirium after surgery, likely a possible complication as well. Good point there, Hannah. The more we can trust our care team when the traumatic experience is happening, the less likely it is to become PTSD or to be an acute stress disorder and then be PTSD after. The more likely it is that we can consolidate that with all of our other traumatic memories because we have trust in the support around us. So when we're coming through the operating room for exposure therapy, you need to be with the person who is going to be taking care of you in that vulnerable period during surgery. Now, whether I'm adding a beta blocker or not depends on the individual. When you want to talk to your doctor about this, and this is one of the top questions I get asked, I often get asked a lot of questions by patients who feel vulnerable, who feel they have not been heard before, who feel they've been neglected and blown off and rejected. Does this sound like, if this is you can let us know because you're not alone. Share it here so people know in the community that this is unfortunately so much more common than we attribute, or than we and we and when we sorry, than we recognize. It doesn't help when that sense of rejection and not being heard comes across as aggression, frustration, blaming the doctor, which I get a lot of. I'll be honest, a lot of patients come to me and they're angry at me. And it's like, I've never worked with you before, ma'am or sir, but let's solve this. Let's help you feel empowered. I want you to be an advocate for yourself. I want you to feel heard. So the first step, and maybe the most important step, is to come at this from curiosity. Because when a patient comes to me, and I can only speak from my personal experience, but I think most other doctors would be in the same page. And I'm not blaming any patients, right? I'm not blaming. I understand that there's a lot of rejection, a lot of gaslighting, a lot of horrible things that happen in underappreciating PTSD. But when we can channel this into a form of curiosity, we help ourselves and we help our doctors better help us. So instead of being like, doctor, I don't want to remember anything. I don't want anything to happen to me. I don't want to be awake for this at all. Instead of that, which I get so often, and it comes from a pressured, fear-induced place, by the way, compared to, doctor, can you please tell me what you're going to do to make sure that I don't feel what's going on? I don't have any added trauma so that I don't have pain. How are you going to help me with that? As a doctor, that is an open door for us to have a solid discussion about how I'm going to help you have the safest surgery. Chris brought up a very good point. Is like pain after surgery. When I've been gaslit, oh, your pain is just, it's pressure, it's not pain, it's going to go away, it's normal, you just had surgery. These are not helpful things if they're out of context, right? So instead of like, doctor, what are you going to do so that I don't have any pain when I wake up? I don't want to feel any pain. I get this a lot as well. It comes from a place of tremendous cognitive rigidity. Can be life-saving in the right circumstances, but before surgery, that type of windup is not helpful, nor is it going to be helpful for a doctor who may not be familiar with what's going on. Compared to, doctor, I've had bad experiences with post-op pain management in the past. Can you please tell me how you're going to help me be comfortable and safe at the same time after surgery? Because I don't want to have that same pain experience again. The two completely different ways of looking at the same problem. One is invoking curiosity that the doctor will pick up on. It's much harder for a doctor to blow that off. I'll tell you that right now. If you're from your heart to heart, coming from a place of curiosity, doctor, how are you going to help me? Please tell me, what are you going to do so that this is safer for me, so that I am more comfortable, so that I am more confident, so that I am more certain that I can trust you with my life? You're trusting your anesthesiologist, your surgeon, your care team with your life. Hopefully, any doctor there is going to give you the same respect that that you are giving them. It's the very least we can do, right? At least we need to reflect that. And if not, gosh, then that has to be acted on. And that's not, it's not right. And there might be room to help provide feedback with the administration there for whoever those care team providers are. Now, there's something so important before any possible triggering experience, whether it be surgery or a medical procedure. And it has to do with, well, it's a very powerful trick that I'm going to share with you, but I see Chris here. I got to answer what you're saying because this video is all for you, Chris. It says, Doc, one of my main concerns is that the trauma is so fresh. And quite honestly, I don't have a trusted advocate. I'm afraid of my issues just being dismissed. Then we have new issues. So there you go, Chris. I hear you. And this is why not only is the curiosity, questioning of your doctor is going to be helpful, but what I'm going to share now is also very helpful. And you've heard me share that concept of the 4 C's and that T for trust. I'm going to share with you why it's so powerful, not only before surgery, but also in the context of PTSD. And by the way, Michaela, I see your comments. Pickle, I see your comments. We'll get to them at the end. But I want you to all remember that these C's are very powerful. And remember, they're certainty, confidence, control. We talked about curiosity already. And that T is trust, which we also talked about, because trust is helpful for preventing acute stress disorder and PTSD. The curiosity we talked about is powerful to approach questioning in a way that does not stimulate our sympathetic nervous system, but also doesn't trigger our care team. Instead, it invites them to help us. Talked about those two. Now, the certainty, let's start with that. The more certain you are in anything you're going to do in life, typically the less anxiety you have. Why? It's because when we are uncertain if we can do what we want to do, we invite anxiety, panic attacks to come in. These derail prior PTSD or prior traumatic episodes from, I should say, they derail our coping mechanisms. Anxiety, fears, and doubts completely undo all the work we've done. So certainty in why you're having the surgery. You got to foster this with yourself, with your surgeon long before you come to the operating room. Doc, can you please tell me, are you certain this is the safest way to move forward? Closely related is confidence. Doc, are you confident that this benefit outweighs the risks for me feeling better, to help me accomplish what I want to accomplish? So Chris, for your elbow surgery, what is it? You can't extend your elbow, you have pain in the elbow. So Doc, is this going to help me do what I want to do with my elbow so I can either, whatever, row my boat, throw my football, pick up my kids, whatever it is this going to help me? Without certainty and confidence, it's very difficult to have anything else shape up for a healing experience. And then lastly is control. Inherently in PTSD, we don't have control over what's going on because there's perceived threats that aren't actual threats, yet our body is responding in a way that is no longer in our control, at least not as in control as it could be. How do we gain control? You know that when we talk about exposure therapy and I talk about beta blockers, we know that we have the inherent way of also gaining control by stimulating our parasympathetic nervous system. So how powerful are our innate calming, our innate relaxation response? Can we tap into that to help attenuate the sympathetic surge that happens when we're triggered by something in the operating room? So if you're doing exposure therapy without access to lipophilic beta blockers, are you doing vagal stimulating maneuvers? The most common way is going to be how you breathe. Now, EMDR, there may or may not be some benefit there. There likely is some benefit, maybe not from a vagal response, but any way to attenuate the sympathetic drive that underlies so much of that wind up phenomenon. That's why when we can maximize our control, by the way, rituals also powerful way, whether it's a mantra, whether it's singing to a song, whether it's requesting a playlist, the more rituals we can integrate, the more control we have. It's why athletes, musical performers, dance performers, they have rituals before they go into these high stress environments because it helps give them a sense of control. So I shared with you many, many tools here. You got to nail the control, certainty, confidence, to use curiosity with yourself and your doctor. Ask the right questions from a point of curiosity so that you cannot be blown off. You have to advocate for yourself. If they are blowing you off after you're coming at it from a place of genuine curiosity, that's something that has to be reported, right? I don't want to report anyone inappropriately, but there has to be the right treatment before the vulnerable period of surgery. Trust in the care team. Without the right trust, any potentially traumatic event has a higher likelihood of turning into acute stress disorder and possibly PTSD. Trust, right? 4 C's and a T. We talked about blunting sympathetic tone, in particular with trauma-focused psychotherapy, and that dissociative state. And if you've ever been in it before, you know what I'm talking about, how unhelpful it can be as we try to cope, as we try to regain control. Disassociating from a situation is almost the exact opposite. So I hope that, Chris, this helps you feel more empowered in how to talk to your doctors, how to frame your questions, and how to ultimately advocate for yourself. There's so many questions here that I want to get to. So please hit that like button if you have appreciated this. Share what you've learned with others because you have more power over your health than you've probably ever been told. All right. Let's get started going through questions. B-Brat says, everyone that has been my responsible driver for multiple outpatient surgeries has not wanted to be my driver ever again because it frightened them so bad. B-Brat, I'm so sorry that you had that experience, but I hope that you know it's not fault per se, but it is a result of a very real mental health condition that manifests through how we interact with others. This goes to show how much the external world impacts our internal world. All right. I've taken arnica and rescue remedy both before and after surgical procedures, so I think it's safe. Sushila, very good to see you. Arnica has some evidence, especially after cosmetic surgeries, for helping with pain and with wound healing. Always talk to your doctor or surgeon first. Rescue remedy, I don't know what that refers to, though. Sorry. Savannah, thank you for the kind comments. Savannah, I'm also sending you positive vibes for starting ketamine on the 24th. Hannah says, I always get delirium after surgery. Seems like it can be helped, although the doctor knows about it. Hannah, we talked about how PTSD, having that amped up sympathetic drive, might, in some patients, lead to delirium after, as can worse inadequate pain control. So if you're in pain, waking up as anesthesia is wearing off from your brain, that can absolutely stimulate delirium, no question. As can the medications that we give, as can hypoxia, hypercarbia, any vital sign abnormalities can all contribute to delirium. So it is a multifactorial condition. Natasha, good to see you. Doc, is it necessary sore throat after general anesthesia intermittent reduction surgery? No, you don't always get sore throat. When this goes into your mouth or your throat, you can get sore throat. I like to recommend licorice before. So if talk to your doctor first always, but licorice is a powerful anti-inflammatory that can reduce sore throat. You can let your doctor know maybe they can actually use an LMA. I don't have one here with me, but the LMA has a lower chance of sore throat. I do it for some turbinate reductions. Depends on how much blood loss is anticipated. Michaela, good to see you on. Have I heard the story of the man who was awake for 17 minutes of surgery? They gave him no memory loss med, and he developed severe PTSD and didn't know why because they didn't tell him. Michaela, that's a horrible story. I'm not familiar with that particular one, but it goes to show just how much knowledge gap there is around PTSD after surgery and how I don't know why we don't acknowledge this because it has such a tangible impact on outcomes. Because when you have that type of PTSD, not only is the rest of your life potentially affected, but your pain after surgery might be worse. Risk of postoperative depression, worse anxiety, blood clots, surgical site infections, poor wound healing, worse scars. This all shows that you can't silo the mental health from the physical health. They are one and the same. Um, Chrissy says, evening. I'm going to have to catch up tonight. Oh, hey. Well, I hope that you have a good dinner, Chrissy. Pickles. My psychiatrist and I are doing exposure therapy with his therapy dogs. Awesome. I have fear of dog germs. Exposure therapy works. There's no way my health system will allow exposure to OR. Well, Pickles, I'm happy that you're starting with the dogs. Please do not let yourself fall into a rigid mindset saying there's no way my health system. Oh, I see. You're saying your health system won't let you. I'm sorry. I thought you were saying you would never do it. Well, Pickles, I hope that you can advocate for yourself. If I can be of service to your health system, want me to talk to a doc there, I'm happy to do that. So they can allow the power of OR exposure therapy to be made available to patients like yourself. Robin, good to see you. Okay. Chris, I empathize with what you're saying about how they totally ignored it. They failed to realize just how horrific your treatment was and how angry you are at being subjected to it. I'm really sorry, Chris. I hope that this is helping you be a better advocate for yourself. Um, all right. I'm going through, I have so many great questions here. I'm working my way down, guys. Works. So Brat says that a therapist for EMDR and hypnosis therapy and has a service doc for PTSD and medical alert. The treatment plans with rescue anti-anxiety medications work. Well, I'm happy, Brat, that you have that level of care team giving you that level of care that's helping. I'm sorry, Savannah, that you didn't have anyone from the anesthesia team meet with you. That's unfortunately what the Western biomedical model treats anesthesia and surgery alike. I'm hoping that we can break that here with this knowledge. Michaela says, every time I've had a procedure with anesthesia, the anesthesiologist comes to talk to me first, and I usually have a joke ready to go to make them smile. That makes me feel better. Michaela, how contagious is that level of emotion? That's so powerful. Thank you for sharing that. And actually, multiple other patients do that with me as well. It does work well. Thank you for sharing that with others. Robin saying that her medical PTSD was caused by an OR team that lied to her after she trusted them. And after going through the records, found out that they made a whole cover up. I am so sorry, Robin, that you had that. And it shows that PTSD happens when we either have no trust or misplaced trust. I'm so sorry that happened to you. I certainly hope that you're able to restore trust in the medical system again. Lynn says, Lynn, I will try to stop covering my lips. Okay. All right. Mary says, would it be okay if I use this in clinical supervision with my psych nurses? Your characterization of PTSD is awesome. They treat patients suffering from this. This is a wow. Well, Mary, it's my pleasure. This is helpful. Please feel free to share this with others. Sarah Keller, good to see you. And Chris says, I can't. Oh, well, thank you, Chris. We'll end with your comment here. It's so kind. Thank you. I can't express to you just how helpful this is, how much I appreciate you talking about it. I'm going to work hard to implement your methods. Chris, I'm wishing you the best, and I hope everyone watching is wishing you the best. I do believe in non-locality to an extent. When we care for others, I believe we also end up caring for ourselves. It's part of the concept of ego dissolution ultimately in psychedelic experiences. But we'll just leave it at this, that by all of us wishing you the best, we're probably helping ourselves as well. For everyone else who's had PTSD, Rob, and everyone else, thank you for sharing your experiences. Remember that you have more power over your health than you've probably ever been told. And if you learned something, do please share what you learned with others to help them also tap into their inner healing potentials. Thank you, everyone. Take care.